Okay. So, good morning, and this is a pleasure for me to introduce our um, next lecturers. We have a theme, I guess. Dr. Holly Erskine, Christina Wallis, and Cordia McGrath from the University of Queensland, Australia, that would give a lecture about adolescent mental health and well-being. So we, I will let I think Dr. Erskine will start first.
Yep, that's right.
Okay, so I think I will give you the time, Holly.
Wonderful. Thank you so much, Amira. Good morning, everyone. As Amira said, I'm Dr. Holly Erskine from the University of Queensland, and I'm here with my colleagues, Christina Wallis and Katia McGrath. And today we're going to be, I guess, speaking about adolescent mental health and well-being, taking this from a very, I guess, public health focused and epidemiological focused perspective. So just some background about myself and the team. So as Amira mentioned, we are from the University of Queensland, specifically the School of Public Health. We're actually physically based at the Queensland Centre for Mental Health Research. I have some pictures out there. And our association with Amira and UGM comes from a big international study called the National Adolescent Mental Health Surveys. So we're working with UGM as well as Johns Hopkins University, and then colleagues in Kenya and Vietnam who are also conducting equivalent projects in their country. So you'll hear more about that later on. But what I'm actually going to start off with today is adolescence. And I guess beginning with, well, what is it and how does it differ from childhood and young adulthood? So adolescence is a critical period of development and also transition from both a physical, cognitive, as well as a social and emotional perspective. Now, I guess there's different definitions of adolescence in terms of both biology, so experiencing puberty, and of course, culturally as well. So the actual definition of adolescence and what it involves can differ both across and within countries. Now, the standard definition is that it incorporates ages 10 to 19 years, but there is a lot of variation in that definition. So, for example, in a lot of societies, adulthood is illegally assumed to begin at 18. Likewise, even WHO sometimes will look at adolescents and youth combined from 10 to 24 years. And many lay people look at adolescence as teenage years, so either 13 to 17 or 13 to 19. So for us, for the purposes of this lecture today, we're going to be looking at mainly the 10 to 19 year age group, as well as a slightly smaller age group, so 10 to 17 years as part of our project. So adolescence sits between childhood and youth, but it is now becoming more and more recognised as distinct from childhood by both researchers and policymakers, as well as international organisations like WHO, the Lancet, and so on. So we've said adolescence is different to childhood and different to young adulthood. So what makes it different? And it's actually about the change, so that transition that young people go through at this age. And I think thinking about it from your own perspective, some of these will start to ring very true. So it's the growth of influences beyond the family. So previously, where the family was the main point of, information and support and really, I guess, the core part of life, in adolescence, that starts to expand and move from the family towards peer groups and social networks. The formation and development of new interests is a big one during this phase, particularly interests in sexual and romantic relationships. And I think what is really keystone or the epitome of adolescence is the fact that there is this risk-taking behavior. And that actually has a biological base. So the prefrontal cortex, so right at the front, that frontal lobe, which is responsible for planning, emotional control, and decision-making, develops a lot later than the limbic system, which is reward processing and pleasure-seeking. And I had it described to me once as adolescence is like having the engine of a Ferrari and the brakes of a VW Beetle. So there's really a big discrepancy in terms of control versus impulse. And that really ties into emotion and reward driven behaviors outweighing rational decision making. Less sensitive to punishments, more sensitive to rewards. And again, all of this can lead to risky behaviors, which is what we see often in adolescence. Also, societal gender differences become more pronounced, and that's really where adolescence begins to become influenced by the cultural context, as well as the technological context and the age and generation in which they're living. And this graph to the right is just a really nice one because it shows that change in influence for adolescents. So previously we have family down the bottom in purple, but peers and media start to become a big influence during this age group. So I mentioned today's adolescents specifically. So we know every generation tends to experience different things. And today's adolescents are really subject to unprecedented global change. So thinking now, so myself in my mid-30s, the technology that was available when I was going through high school and even university is now completely different for today's adolescents going through the same. So the rise in technology and technology's influence, particularly in social networks, has just had a massive impact, both good and bad, on adolescents. And then, of course, we'd be remiss, I think, to not mention the impact of COVID-19 as really, I guess, a generational shock to today's adolescents. And when we are talking about today's adolescents, we are talking about a big proportion of the global population, so around 16%. And within Indonesia, which has a bit of a younger population, 17% of the Indonesian population. And I'll just note that in some of the conferences and some of the work I've done in Indonesia, this generation of adolescents is being referred to as the golden generation. I won't try to pronounce that in Bahasa Indonesia because I'm sure I would butcher the pronunciation. But I guess thinking about adolescence, not just as important now, but also important later, and both for the adolescent or the person themselves, but also for the economy, because today's adolescents are tomorrow's workers. So thinking about that economic transition and that economic load that's taken on by this generation. So then bringing adolescence back to mental health. And why is mental health so important in adolescence? Now, adolescence is a really critical period for mental health. Many mental disorders tend to have their first incidence or their onset during adolescence, sort of around 14 years of age. And poor mental health in adolescence has impacts both now and in the future. And these impacts are related to each other as well. So thinking about negative or adverse impacts on education, so not being able to achieve in school as much as an adolescent wants to, that then starts to have snowballing effects on their ability to work later on or to get a job. Likewise, there are social impacts as well, both in their current family, with their peer groups, and then with their future family as well. So that does sound, I guess, all very doom and gloom. But on the flip side of that, what that tells us is that good mental health or intervening in poor mental health during adolescence can have a myriad of benefits, both now and in the future. And we do know that mental health in adolescence is influenced by a range of factors. So thinking back to the previous couple of slides, so talking about what influences adolescence, we know that peer groups and the type of peer groups they associate with can have a big impact. Likewise, education, and then expanding out to things like bullying and substance use. That's really a lot of our risk factors. At the same time, there can be protective factors as well. So strong or positive self-esteem, good parenting, family functioning, and so on. And there are other factors in there as well. So around service use and ability to access services, as well as the actual services themselves. And I guess just before I pass over to Christina, I think the lens that we look at mental health with is that there is no health without mental health. So it's impossible really to be completely healthy without having good mental health. So there's no mental health without good physical health. Likewise, there's no good physical health without mental health. So we see health as on, I guess a collective, a spectrum. So now on that note, given we've touched on mental health, I'm going to pass over to Christina, who's going to go more into mental disorders themselves.
Thanks, Holly. Just share my screen for you now. Perfect. Okay, hopefully you can see that. So as Holly mentioned, my name's Christina. I'm a research officer with Holly and Katia on the NAMS team. I'm going to be talking a little bit more in depth about mental disorders and how we define them. So the first thing is looking at how we define and understand the terms mental health and mental disorders, because they're both terms that are thrown around a lot, so they warrant a little bit of a closer look. I guess the way that we really understand mental health is it's this spectrum, and it ranges from good mental health at one end to poor mental health at the other. And when we talk about good mental health, I think it's worth understanding what we mean by that as well. So good mental health is where people have minimal psychological distress day to day. They're able to engage in their everyday activities and participate in life in a meaningful way. And then when they do experience the inevitable stress of everyday life, because that can't be avoided, so that might be a stressful assignment or a stressful work situation, they're able to manage that experience. They're able to really use their inner resources and bounce back from that experience or that situation relatively quickly. So we've got the spectrum, good mental health to poor mental health. How do we define where mental health becomes a mental disorder? And I guess it's where someone's mental health becomes so poor that it begins to significantly impact their thoughts, so their everyday thinking, their behaviors, and their thoughts, feelings, and behaviors. And so I guess we draw this line across the spectrum of where that tends to sit along the poor end of the spectrum. Okay, so let's go further into understanding mental disorders more specifically. So a mental disorder is a clinically significant behavioral, so how people are acting and feeling, or psychological, so what they're thinking, syndrome or pattern that occurs in an individual and is associated with present distress. So that might be a painful symptom such as a depressed or sad mood or worrying about a social situation. Disability, where you've got impairment in one or more important areas of functioning. So with something like severe depression, you might see an individual who finds it really hard to get out of bed every day and brush their teeth, for example. And then lastly, associated with a mental disorder is a significantly increased risk of suffering death, pain, disability, or an important loss of freedom. So how does that differ from a mental health problem? A mental health problem is really similar to a mental disorder in terms that it also interferes negatively with how a person thinks, feels, and behaves, but it's to a far lesser extent than a mental disorder. So an example of a mental health problem might be someone who's going through a breakup with a partner, and as a result, they experience symptoms that are associated with depression. However, they wouldn't meet the criteria to be diagnosed with major depressive disorder. Another example is someone that might be feeling a bit anxious about sitting a final school exam. So they have anxiety symptoms, but again, it wouldn't be severe enough and they wouldn't meet criteria, for example, for generalized anxiety disorder. So mental health problems can be experienced temporarily, or as I've just mentioned, as an acute reaction to the stresses of everyday life. So how do we define mental disorders? So obviously one of the difficulties, as I'm sure you're aware, with mental disorders is that there is no blood test or scan that you can do that tells us that this person has a mental disorder and this person does not. So instead, the criteria that we use to diagnose people with disorders, are really through two major manuals. So the first being the Diagnostic and Statistical Manual of Mental Disorders. So we're up to the 5th edition of that. It's been through, obviously, you can see this list of other DSM versions over the years. The other major manual that we use is the International Classification of Mental and Behavioural Disorders. So it's important to note, I think, that most of these manuals have been developed within a Western context. And the way that mental disorders have been defined have evolved quite significantly over time. So if you looked at what was in the first version of the DSM compared to this version, DSM-5, you would see a major difference in the inclusion of mental disorders themselves, as well as the symptoms and the criteria that make up a mental disorder diagnosis. So what are the different types of mental disorders? So this is a chapter list of what's included in the DSM-5. So you can see it's very broad. It covers a very wide range of different types of disorders. So you've got in here just a few examples: schizophrenia, a chapter on depressive disorders, anxiety, trauma, eating disorders, personality disorders, and even substance use. There are 157 unique disorders in the DSM-5. And this manual contains a very detailed explanation of each disorder, alongside very detailed and clear criteria of what an individual would need to present with, what types of symptoms, how long those symptoms need to have gone on for them to meet criteria to be diagnosed with that disorder. It also is really helpful because it contains a lot of the recent literature around what risk factors are associated with the mental disorder, culture and gender related features. And for some disorders, even additional specifiers. So for example, with PTSD, there is an additional specifier where you can diagnose someone with a specifier of delayed onset, so that their symptoms of PTSD were delayed compared to other people who perhaps had their symptoms straight after the traumatic experience. So I guess it just provides an additional level of detail and information. Okay, so honing in a little bit more on mental disorders in adolescents. There are 6 main disorders that I wanted to highlight and go into a little bit more detail today. And the reason that these 6 have been chosen is because they are the ones that tend to be the most burdensome and the most prevalent in that adolescent age group. So we've got 6 disorders here, and they are grouped into 2 categories, further grouped into 2 categories. So we have internalizing disorders, and that's where symptoms of internalizing disorders tend to be experienced internally. So for example, feeling sad or feeling anxious. So we've got in this group 2 types of anxiety: social phobia and generalized anxiety disorder, as well as major depressive disorder and post-traumatic stress disorder. So then we've also got externalizing disorders. And this is where symptoms tend to be more outward facing. So in other words, these are the symptoms that another person could observe. An example of an externalizing symptom would be being hyperactive, for example, or even being aggressive. Okay, so we might go into a little bit more detail on each of these disorders, just to give you a bit of context around what you would need to see in a person, what they would need to present with, what criteria they would need to meet, what symptoms they would need to have to receive a diagnosis. So first up is social phobia. And social phobia is categorized by fear of one or more social situations, where the adolescent is the focus of other people's attention, and that attention causes feelings of embarrassment or humiliation, which often leads the adolescent to avoiding these social situations that cause fear or enduring them, but absolutely dreading that experience and just wishing that it was over. So more specifically with the criteria, social phobia, you've got to have a marked fear or anxiety about one or more social situations where that individual is exposed to possible scrutiny by others. And often, these individuals feel as though other people are scrutinizing them or are judging them. But that is, not necessarily the case. Often it's that perceived judgment of others. So that could be occurring in social interactions. So meeting new people is a really big one for social phobia. Also being observed. Some people are very fearful and worry a lot about, for example, eating or drinking or writing, getting up in front of others in terms of being observed. And then the last example here is performing in front of others. So I think, a lot of us can understand that giving a lecture or a presentation can be anxiety provoking. For people with social phobia, this would cause a lot of distress. So an example might be giving a lecture, obviously, but also in the context of an adolescent, it might be performing in front of their peers, getting up at a music concert and, playing their instrument. Or performing in the school play, those sorts of things. So the individual fears that they'll act in a way that shows their anxiety symptoms, and then that will be negatively evaluated by others. They'll be judged by others, which will ultimately lead to social rejection. These social situations that they're fearful of almost always provoke fear or anxiety. They endure or avoid the situations altogether. The fear or anxiety is well out of proportion to the social situation. So as I mentioned before, it's really normal and common to feel anxious about giving a presentation in front of others. But most people can feel a bit of anxiety and get through it okay. For people with social phobia, that fear is intense and significant, and it may impact their functioning in the leading up weeks to their presentation and really impact them. So it's far different to someone that just feels a little bit nervous about a situation. And then the fear or anxiety needs to be persistent. So lasting consistently for around that 6 months or more mark is how we define it in the DSM. With all of the criteria that I talk about today, I think the last stop point for each of them is that for someone to be diagnosed with that disorder, the symptoms need to cause clinical levels of distress or impairment. So just if somebody has a lot of symptoms about something, but it doesn't seem to bother them, or it doesn't stop them living the life that they want to live, then it wouldn't necessarily be categorized as a mental disorder. Perhaps it would sit more on the side of being a mental health problem. Okay, let's move on to generalized anxiety disorder. So GAD. GAD is characterized by excessive anxiety and worry about a number of events or activities. So the intensity, frequency, and duration of the anxiety and worry is, again, it's out of proportion to the actual likelihood or impact of the anticipated event that they're feeling worried about. And occasionally there are adolescents out there that feel very anxious and they find it quite hard to pinpoint what they're anxious about. So that does occur as well. If they can't identify an event, they can still be diagnosed with generalized anxiety disorder. So just looking at that in a little bit more detail, they have that excessive anxiety or worry that occurs for more days than not for at least 6 months. So you can see that 6 months was consistent in the GAD criteria as well as social phobia. The individual finds it really hard to control this worry. So they can't just put it to the back of their mind. They need to experience at least 3 or more of these symptoms. So they're really restless and they struggle to relax. They might be quite tired, easily fatigued, difficulty concentrating, or they have this sense of their mind going blank, irritability, muscle tension. Often with people with generalized anxiety disorder, they don't realize how tense they are. They might be tensing their muscles. A lot of people accidentally, they don't realize that they're holding their breath even. Some sleep disturbance as well as the last symptom. And again, that all needs to cause distress or impairment to meet criteria. Okay, let's move on to major depressive disorder, or MDD. So MDD is characterized by a period of at least 2 weeks during which there is either a depressed mood or a loss of interest or pleasure in nearly all activities. Then an additional 4 depressive symptoms need to also be present. So if we look at that in a little bit more detail, so in total, you need 5 symptoms during the same 2-week period, and at least one of them needs to be the top 2 on this list, so that depressed mood or the diminished interest or pleasure in activities. Other symptoms that may be present with MDD are changes in weight or appetite, changes in sleep, so struggling to get to sleep or feeling sleepy all the time. The other thing that's quite common with MDD is people might find it easier to fall asleep, but then they will wake up in the middle of the night and can't get back to sleep then. A sense of being agitated and really struggling to wind down, fatigue or loss of energy, feelings of worthlessness or guilt. And often this will come out in a cognitive way. So people will say, I feel worthless, or it's my fault, everything's my fault. So you'll start to hear those sorts of things come out of somebody's mouth in terms of their dialogue, an inability to concentrate or make decisions. And you can see how that can be very impactful on someone's ability to operate in the workplace or even at school. And then lastly, the last symptom is recurrent thoughts of death and suicide. And again, these symptoms need to cause that significant levels of distress or impairment. Okay, so post-traumatic stress disorder, PTSD. So PTSD is characterized by the development of a set of symptoms after experiencing or witnessing an extreme traumatic event, which is often violent and involving threatened or actual death or serious injury. So some examples might be being the victim of an attack, being in a serious car accident, being in a natural disaster and fearing for one's life. So the criteria for PTSD, the first one is exposure to a traumatic event. So that might be as a direct experience, so it happened to you, or it might be a witness where you see it happening to someone else. It can also be where you hear about a traumatic event that happened to, it usually has to happen to a really close family member or friend. So associated with that traumatic event, criterion B is one or more intrusive symptoms. So examples of intrusive symptoms include recurrent and involuntary memories of the event, very strong, vivid and distressing dreams about the event, Disassociative reactions and flashbacks. So that might be where an individual really believes, or they feel and they behave like the event is occurring again. And associated with that is in this intense psychological distress and a physiological, so bodily reaction to things that then remind them of the trauma. Criterion C, so that associated with these symptoms and these memories of the event, the person has this persistent avoidance of anything that's associated with the event because it's so distressing for them. Criterion D is negative changes in thinking and feeling. So the person may develop negative thoughts about themselves, others in the world. They may even develop some distorted thinking about the cause or the consequence of the event that occurred. They may experience a persistent negative emotional state. Some people start to develop feelings of detachments from others, so the sense of being really alone. And then another example is diminished interest in activities, which we also saw in the MDD criteria. Then criterion E is negative changes in arousal and activity. So some examples of this might be, the person has started to develop a lot of irritability. Perhaps they've changed their behavior and they've become a little bit more reckless. Or conversely, maybe they've become quite hypervigilant and overcautious in their behaviors. Something else that we see in this criterion is also sleep and concentration difficulties. So the duration of the intrusion symptoms, the avoidance of stimuli associated with the event, and negative changes in thinking, feeling, arousal, and activity need to be happening for more than a month. And again, like we've seen with the other criteria, need to cause significant distress and impairment. Okay, I hope everybody's taking that in okay. I know it's a lot of information. I've got two more to get through. We're going to look at ADHD now. So attention deficit hyperactivity disorder, or ADHD. So ADHD is characterized, the essential feature of ADHD is a persistent pattern of inattention or hyperactivity impulsiveness that is more frequent and severe than in other children of the same age or developmental level. So you can actually be diagnosed with ADHD with just an inattentive subtype, or just a hyperactive subtype, or a combined subtype where the adolescent meets the criteria for both inattentive and hyperactivity symptoms. So you need 6 or more symptoms in either the inattentive or the hyperactive, or in both, to meet ADHD criteria. So some examples of inattentive symptoms might be the adolescent may have difficulty sustaining attention or following through with instructions. They might find it difficult to organize themselves or tasks. They may be really easily distracted, or this may manifest in a way that they become quite forgetful in everyday life. So then when we look at hyperactive and impulsive symptoms, some examples there, you may see an adolescent who's very fidgety with their hands. Perhaps they are tapping their feet on the ground. They may struggle to stay in their seat where it's expected to do so. You can imagine this playing out in the classroom. They may find it difficult to play quietly. They might talk quite a lot, so you see that excessive talking. They might find it really hard to wait for their turn in conversation, and similarly wait for their turn in a game, and they may interrupt others. So you can see that those two groupings of symptoms are quite different, but often you will see an adolescent that has that meets criteria for both. So importantly here, these symptoms, because you can listen to those symptoms, And probably everyone as an adolescent has had trouble concentrating at some time in their life. So some of these things are very normal. But in order to meet criteria, the symptoms that the adolescent is experiencing do need to be inconsistent with the young person's developmental level. So you would expect someone at a certain age to be able to stay seated throughout one classroom, one class period, or one class time. But with someone that has a hyperactive ADHD, they may find that so hard and never quite be able to achieve sitting down, for example, for a full 45 minutes. So several of these symptoms need to be present prior to when the adolescent was 12 years of age. And the symptoms need to occur in at least 2 settings. So for example, in the school and in the home. If you only see them in the school or you only see them in the home, it wouldn't quite meet criteria for ADHD, and you'd be wanting to explore a little bit more around why that might be happening in just one setting. Are there certain triggers in one setting that then lead the adolescent or the child to behave in a certain way? And then again, in terms of impairment, so evidence, you need evidence that these symptoms impact that adolescent across multiple areas. So with their friends, with their studies, or with their work. Okay, I think this is the last disorder that we're going to cover in detail. So conduct disorder. So conduct disorder is characterized by a repetitive and persistent pattern of behavior that violates the basic rights of others or major societal norms or rules. So to meet criteria for conduct disorder, you need to have at least 3 of 15 symptoms which need to be present in the past 12 months, with 1 symptom present in the past 6 months. So there are 4 symptom categories. The first one is aggression to people and animals. So for example, symptoms under that category would be where an adolescent bullies, they threaten, or they might intimidate others. They might initiate physical fights or use weapons to cause harm to others. They may be physically cruel to people or animals. Destruction of property. So an example of this would be where an adolescent deliberately starts a fire or deliberately sets out to destroy another person's property. That might be their home or their car. The third category is deceitfulness or theft. So this might be where you see an adolescent breaking into others' homes. They might start lying to obtain goods or favors or get out of obligations. You might see shoplifting or stealing things in that category. And then lastly, serious violation of the rules. For example, that includes staying out late at night. Usually that's before the age of 13 because it's recognized after that age it may be appropriate for some adolescents to do that. Running away from home or being truant from school. And again, these symptoms need to cause clinically significant distress or impairment. Okay, so now that I have absolutely bombarded you with all of that information, I'm going to hand back to Holly, who's going to talk a little bit more around how we measure that, how we measure mental disorders.
Wonderful. Thanks so much, Christina. So I'm just switching on my screen now. So hopefully you're seeing the title slide that says measurement. So Christina has taken us through how we define mental disorders, how mental disorders actually differ in terms of concept from mental health, and then some of the different types of mental disorders that we often see during the adolescent period. So then taking a step back from that, the next question is then, in the population, how do we measure mental disorders to get the data that researchers need, that policymakers need, that other international organizations need? So I guess when we're talking about population level data, there's a couple of different approaches that we can take. So when we're interested in the population, if we only look at clinic or hospital data, all we're getting a sense of there is the prevalence or how common mental disorders are among people who access services. So what we're really interested in is in the entire population, what is the prevalence of mental disorders among adolescents? And the way we generally do that in epidemiology is we do surveys. And surveys can take many different forms, from comprehensive household surveys through to very simple, short online surveys. And of course, the quality in the information that you get varies along with your method. But thinking back now to comprehensive, sort of the more household surveys, so going to someone's house and interviewing them, or having people come to a location and be interviewed, as I mentioned, there's essentially two different approaches. So we can have a clinical assessment conducted, and this can be done by a psychiatrist or a psychologist or someone else who is clinically trained to assess mental disorders. Now, there's a big advantage to that because, of course, a psychiatrist or a psychologist or another individual is trained to deep dive into the individual's answers. So they might hear something that the adolescent or their parent says and know that, oh, I think I need to investigate that a bit more. I think I need to sort of delve into this. And they might, uncover symptoms that wouldn't be easily identifiable. They can also consider a whole bunch of different individual factors. So what is the adolescent's home life? Where are they in a particular country? What actually might be influencing the information that they're getting? There are, of course, some downsides to this. So a clinical assessment, when done comprehensively, is often quite lengthy. Also, if we're wanting data that's representative of a population, it is very rarely feasible to do this on a large scale with a whole team of psychiatrists interviewing, thousands of people. There's obviously a limit in how many psychiatrists are available. There's also quite a significant cost burden as well. So then the other approach to try and combat some of those things is to have what we call a standardized tool, which is really just a very structured questionnaire. Now, these questionnaires are often developed so that they can be administered by a layperson. And what we mean by a layperson is someone who is trained to use that instrument, but they don't have any formal clinical training themselves. So the downside, looking at these standardized tools compared to clinical assessment, is there's no scope for additional information. So the interviewer asks the questions as written, and that's it. That's all that's recorded. Also, a lot of the standardized tools that are actually available are either developed in the US or the UK or sort of other Western cultures. And so they're sort of developed for those cultures and then later adapted, rather than being built up for the particular culture where they're trying to measure. The plus side of standardized tools is because they use lay people, they're structured, they can be feasibly administered at a population level. So a lot of the data that I'm going to be talking about is data that comes from these kinds of surveys. So I guess based on that then though, what do we actually know about the prevalence of mental disorders in Indonesian adolescents? So what I'm going to touch on here is some data from the Global Burden of Disease study. So some of you may or may not be familiar with the Global Burden of Disease study. It's run out of the University of Washington at Seattle. And basically it uses all the global epidemiological data. So that's data like prevalence and incidence, deaths, remission, and so on, to estimate the prevalence and disease burden for different conditions. So not just mental disorders, but a whole range across all countries, all different age groups, both sexes, and by year as well. So starting from 1990 through to, I think it's currently 2019. So it's a really, really big study that pulls all data that meets the inclusion criteria and models that to get a sense of, well, what is the prevalence of mental disorders and other conditions in these countries? So for Indonesia, for our age groups that we're interested in, for 10 to 14 years old, the estimated prevalence is 10.7%. So that's all mental disorders combined. In 15 to 19 years, it's slightly higher at 11.4%. And what we've got on the right-hand side here is actually a rank in terms of big disorder and disease groups for 10 to 14 years. So this is looking at disability, and disability is essentially prevalence, so how common it is, multiplied by a disability rate, or how bad it is, to give us years lived with disability. So in that age group, how many years are actually being lost due to living with a disability? And mental disorders in 10 to 14 years and also 15 to 19 years is the leading cause of disability both globally and in Indonesia for these particular age groups. Now I'm going to do something somewhat risky and have a look live at some of the GBD comparisons, just so you can get a sense of where this epidemiological data is actually being used, as well as what it's actually telling us. So what I'm going to do is I'm going to skip back to this diagram, and hopefully all of you can see this diagram here. This is publicly accessible, provided by the University of Washington. And what we have here is a tree map. So for those of you who aren't familiar, a tree map is essentially just a square pie chart. And the settings I've got on here at the moment are, we've got years with disability, so that's our disability measure, so prevalence multiplied by a disability rate. We've got Indonesia in 2019, and we're looking at 10 to 14 years specifically for both sexes. Now, the size of the box essentially equates to how much of the total disability a particular group is contributing to. So basically, the biggest box makes the biggest contribution. And mental disorders, as you can see, are the leading cause of disability in 10 to 14 years. And actually, compared to 15 to 19 years, you'll see the same again as well. So you'll see a slight shift, a slight increase, but mental disorder is still the leading cause. And just out of interest as well, you'll see we have these different colors here. So blue are our non-communicable diseases, red are our infectious or communicable diseases, and green is our injuries as well. So just if you're ever using this yourself, this is what the actual colors mean. So it just gives us a really interesting picture of what the actual size of the burden is in Indonesia for mental disorders in adolescents, and also how it relates to other conditions that we commonly think about in these ages. So likewise, now we're looking at something slightly different. We're looking at the percent of total YLDs. So it's almost like having a mini tree map for each age group. And this shows us how, I guess, health burden changes across the lifespan. So we've got our individual age groups down here, and then we've got our percent of the total disability here. Now, as you'd expect in the infant or younger ages, so our under ones, we have a lot of our infectious diseases, which we see basically across the board. Then sort of in childhood, we start to see this dark blue have a much bigger impact, and that's our mental disorders. So really mental disorders start to come to the fore here. Remember that we spoke about those risky behaviours as well. So likewise, in adolescence, we also see more injuries start to come up as well. And then as we move through the lifespan, we start to see some other non-communicable diseases really come to the fore. So blue and purple in this graph are both non-communicable diseases. And we see things like neoplasm. So as you'd of course know, that's cancer. Cardiovascular disease in older ages start to come into play. So I guess, I've touched on a few different disorder groups there, but the reason I show this graph is if we think about where mental disorders are beginning, so in adolescence, and where they're having their most impact is the ages where you're expected to be your most productive economically. So from a country point of view, having accurate data to inform this kind of a pattern is really crucial because it helps policymakers, set their priorities in terms of health. And this again is the same graph that I showed you on the slide. So this is an arrow diagram. And this actually is just showing you the difference between 1990 and 2019 in terms of rank. So this is how the different disorder groups relate to each other. And you'll see from 1990 through to 2019, mental disorders remained #1 in terms of years lived with disability. And it's the same for 15 to 19 years as well. You just see a slight uptick in some of the injuries. So I guess I just wanted to show you that to get a sense of, one, where the data that we're talking about is actually used, and then two, what it actually shows us as well. That, however, does lead us to challenges with this data. And I'll come back to GBD in a moment. But I just want to take you right back to what Christina started off with when she gave her section of the lecture, which was around definition. So as Christina mentioned, diagnosing mental disorders is not as straightforward as diagnosing a bacterial infection or a virus, because we don't have a simple blood test that says yes or no. Basically, what we're doing is we're drawing the line between what is, expected behavior or experiences, drawing the line and saying, okay, anything that goes beyond this, that meets a certain number of symptoms and certain criteria, that is a mental disorder. But that starts to get pretty tricky when we're looking at children versus adolescents versus adults. So often the same thresholds are applied to all of these age groups. But the question is, really how appropriate are they? In ADHD, for example, there's a slight adjustment in number of symptoms. So I think for adults, you only need 5 symptoms rather than the 6. But again, it's often quite a small change in the diagnostic criteria for what is actually clinically seen as a big difference in terms of presentation. Also, when I mentioned the standardized tools, so those questionnaires being developed in a Western context, it's the same with the DSM and ICD as well. And almost to the point where US versus non-US in DSM is actually really can make a big difference. So the example we often use in that is, so ADHD and being driven, acting as if driven by a motor. Now, at least for me, I know what that is trying to get at, but trying to rephrase that or translate that or apply that even to an Australian context can be really challenging. And that's not just a challenge in the tools itself, that's actually a challenge in the definition. That is literally a symptom in DSM. Following on from that, we then have changes over time. So Christina had that photo up that showed the different DSMs over time. And I guess the challenge in that is that something that was considered a mental disorder no longer is, and also vice versa as well. So I don't know if some of you are into reality TV like I am, but some of you might be familiar with some of those shows like Hoarders, which was a big one coming out of the US sort of in the early 2000s. Hoarding disorder is now actually its own diagnosis in DSM, coming under things sort of similar to OCD. And I guess I just flag this because it means that prior to it being a diagnosis within DSM, it's often difficult for people to get help if it's not a recognized diagnosis. So just thinking about the actual implication of those changes over time for clinicians and people trying to diagnose. And then, of course, like what I mentioned with Western versus non-Western, there's a relevance of scoring algorithms across cultures, which is a bit of a mouthful. But essentially, as Christina mentioned, there is very set criteria in DSM that you're required to meet in order to meet diagnosis. Now, again, those criteria were written in a Western context and don't necessarily take into account the different presentations of symptoms. So we know in some cultures, it's often physical symptoms that are more present than the actual cognitive symptoms. So for example, in anxiety, a lot of people in some cultures will report racing heartbeat, sweaty palms, headaches, and so on, rather than actually reporting, symptoms of anxiety, so nervousness or worries. So there is a potential there for people to be misdiagnosed. That then goes into, I guess, challenges with measurement. So the things that I talked about before, so those standardized tools. Now, I'm sure Amira could speak to this much more than I could, but in our project that we worked on together, translation of these instruments proved really challenging just because of the concepts that we're trying to measure, and particular nuances in English that aren't necessarily in other languages, and vice versa. We found often in English, it would be one word for something, but in other languages, it would be multiple words with different nuances as well. There's also culture and language. So in terms of idioms, so remember the acting as if driven by a motor example, there were many others throughout as well. So holding someone up, snatching someone's purse, things like that, that until you look at it from a different perspective, we didn't realize how westernized that language was and those metaphors and those idioms were. Similarly, with these tools, there can be a bit of a challenge with culture and the way in which they're delivered. So I use the example of my colleague who is running a survey in Indigenous Australians. And as I mentioned, those standardized tools have a very structured approach. But culturally, for Indigenous Australians, that is not how any kind of health issue or anything is really spoken about. It's spoken about in a much more conversational way, and that is how better data is actually gained. But that is not what standardized tools allow for. So there's really this push and pull between trying to get the best quality data, but trying to maintain consistency across different contexts. That then feeds into challenges with little or no data. So we can, I think, to a point, standardize our definitions and our measurements as best we can, noting those limitations. But again, then there are other factors that come in that contribute to not having a great deal of data. So things like, cost, priorities, and so on. So a 2016 study actually analysed the mental disorder data that's included in the prevalence and disability estimates for GBD. So those graphics that I showed you, this study actually looked at what data was informing those estimates. So how much of those estimates was actually informed by data and how much was actually filled in, so to speak, by the modelling. And what it found was actually of the global population aged 5 to 17, so we're looking at children and adolescents here, only 5.7% of that population was represented by the available data for mental disorders. So what that means is that for mental disorders, globally, we essentially only have 5.7% of that population aged 5 to 17 represented by the available data. So I use black for this circle here, which is a bit ominous and what I don't normally do in slides, but it really is just to show that's essentially the void. So there's a 94.3% of the child and adolescent across the globe we have no information for. So then what does it look like for Indonesia? Only 0.07%, so less than 0.1% of the population aged 5 to 17 actually has data that can inform the mental disorder modelling and prevalence in GBD. So I guess then the question is, well, does that actually matter? If we can model it, then why should we worry about not having much data? So just skipping back then to some of those visualizations that I showed you, what I didn't show you was the actual uncertainty around these estimates. So we're going to look at a different couple here. So what we've got here is prevalence for mental disorders in Indonesia for our 10 to 14 year age group. So this is prevalent cases per 100,000, so it's any mental disorders combined. And this is from 1990 through to 2019. Now the bars here, I'm sure probably all of you have done some stats training, but we have our uncertainty intervals. So obviously the lowest possible number through to the highest. And the bigger the uncertainty intervals, the less confident we can actually be in this estimate. And the reason that I show this graph is what you'll see is 1990 versus 2019. There is no statistically significant difference because these uncertainty intervals are all overlapping. So what that means is that we don't actually really know for sure, has there been a change in mental disorders prevalence in 10 to 14-year-olds between 1990 and 2019? Is this line actually going up? Are mental disorders becoming more prevalent? Mental disorders, are they going down? Have some interventions actually come into play? Do we see any spikes in mental disorders? So sort of around the 2004 tsunami, do we see a spike in mental disorders as a result of that from things like PTSD or anxiety or depression? So the challenge with not having good data or not having any data is that we can't answer those questions. And if we can't answer those questions, then we don't know what is required because we don't know what the problem is or the scope of the problem. And we also don't know whether interventions have worked or haven't worked. So from a policymaker point of view, not having the evidence to inform those kinds of decisions is really, really challenging. It also makes it difficult to look at any country compared to, other like countries or just globally as well. So this is a similar graph to the one you saw before. It doesn't have uncertainty at the moment. I've actually flicked back to YLDs here. So we're looking at disability per 100,000. Why don't we actually flick back to prevalence, which is always somewhat risky to do. But if we just let that load. So this is the actual prevalence. And you'll see we've got different countries here, mainly in the Southeast Asian region. And Indonesia is in our dark green line there that's just been highlighted. So this is essentially the exact same graph that you just saw before, but instead now we've got different countries in the mix as well for our 10 to 14 years. So you would look at that and think, okay, Indonesia in the Southeast Asian region is sort of mid-range. We've got Korea up here, which is a bit higher. I think this is Bangladesh down here. But what this isn't showing yet is uncertainty. And if we turn that on, then you'll see that essentially, bar a couple of very few or limited exceptions, all the uncertainty overlaps. So again, we can't actually tell, are we seeing differences by country? And from an within country perspective, that matters because we then can't look to other countries and see, well, what are they doing that is improving their prevalence, or what has happened within their country that may have impacted prevalence and can help us, inform our policies or our interventions. So, I guess I just wanted to highlight that it's a very public health perspective, but I guess it is important to know that if we don't have good data, we're not going to have good decisions. I'm going to try to flick back to my slides now. So what I just showed you was very sort of GBD, I guess international big study kind of focused. And when I spoke about limited data, obviously coming at it from a GBD perspective, because I know some of you will be sitting there saying, well, we do have some data in Indonesia, it just wasn't in that study. And you're absolutely right. But there are challenges with this other existing data that we have for Indonesia, and this is for virtually every country across the globe as well. So remember, Christina mentioned the difference between mental disorders and mental health problems. So a lot of the available data that we have for Indonesia, for Australia, for many countries, is that the data looks at mental health problems rather than mental disorders. And they measure these using short symptom measures, and they're not those standardized tools that we spoke about before. which means that we still don't know very much about mental disorders or what, most importantly, services or supports may be needed for those higher thresholds. Similarly, we can have studies that do look at mental disorders, but are quite limited in terms of their sample. So they might actually look at certain cities or only look at males. Or in this one example, they did look at 14 to 18-year-olds, but were only interested in those young people who'd been exposed to the tsunami disaster of '04. So what that means is that we can't generalize this information to mental disorders across the whole of Indonesia. So we can't use this data to inform decisions about the rest of Indonesia. And then I guess following on from that is what I mentioned before, is clinical samples or hospital data, which tend to be the most commonly available, only tells us about people who access services, and importantly, people who are able to access services. And we know that most young people with mental disorders either don't seek or receive help, and often there are few or no services available. So what this all boils down to is that currently there is no nationally representative study reporting the prevalence of adolescent mental disorders in Indonesia until now. And with that, I will pass over to Katia.
Thank you, Holly. Hi, everyone. My name's Katia, and I'm a research officer for the UQ team as well. And hopefully everyone can see my screen. So Holly's just spoken about what the global coverage is for different mental disorder prevalence, what the data is like for Indonesia, and why this gap in prevalence data for Indonesia is such a problem, and it is something that needs to be addressed. So all of this is the primary reasoning and motivation behind the Indonesia National Adolescent Mental Health Surveys, or INAMS for short. So this is a project that's currently being led by UGM, and we're working in collaboration with UGM, and they're also working with two other universities, USU and Unhas, in Indonesia. And INAMS is a part of a broader study called NAMS, which is being led by UQ here in Australia. So NAMS also has surveys being done in Kenya and Vietnam to get this nationally representative data. And what it is, so we have surveys being conducted with households across Indonesia of adolescents within that household, and also with that adolescent's primary caregiver. So it's conducting over 6,500 interviews with households across 188 different enumeration areas, and data collection has been occurring over the past year. So the thing that's actually being, what we're interviewing people about, it's the prevalence of 6 common mental disorders in adolescents. So it's those ones that Christina spoke about before, as well as looking at different risk and protective factors that might play a role in mental health, demographic information, as well as whether these households are using services and barriers to care that they might be experiencing. So you can see here on the screen an overview of all of the different modules that we're looking at in the actual survey. So there's an interview that's done with the parent or the primary caregiver, and then a separate interview that's done with the adolescent. So you can see in the purple, there's a different module for each of those 6 disorders. In the green, we've got our different risk and protective factors, as well as that other information that we're collecting information on. So these surveys are the instruments are relatively similar for KNAMS and VNAMS as well. Obviously, we've translated them into the local country's language. And as Holly said, there's been some cultural adaptations that have been really important to making sure that the interviews and the questions actually make sense and are relevant to the adolescents and parents that are being interviewed. You'll see as well in the blue, we have those 2 modules. And these are modules that are specific only to the INAMS instruments. So these are things that the research team felt were particularly important for an Indonesian context and something that we wanted to get data on. You'll also notice next to those mental disorder modules, it says DISC 5. And this is one of the standardized instrument tools that can be used in surveys. So this is the diagnostic interview schedule for children. It's a fully structured instrument, and it can be used in either children or adolescents to assess different mental disorders that they might have. What we've done for NARMS is we've taken 6 of those disorders and incorporated them into our instrument. And the really good thing about the DISC-5 is it's something that you don't need to have clinical training for. So Holly mentioned before lay interviewers. So these people have been trained on using the instrument, but they don't have specific clinical assessment knowledge. And this is something that's really important for a national survey. So rather than being limited in only having a few clinicians available, we can have a large number of instruments conduct the data collection across the country and get a large number of information of different households. So the diagnostic criteria that the DISC-5 uses is based on the DSM. So you'll note here the DISC-5 is version 5. So this has been updated to match the latest version of the DSM criteria. So it asks about a series of different symptoms, whether or not the adolescent has them. And it also asks about distress and impairment in different areas. So that might be at home, at school, or in other areas of the person's life. And if that adolescent has met a sufficient number of the symptoms and also has that distress or impairment, they'll be given a positive diagnosis on the DISC-5 for either one of the mental disorders, or they can also have several positive diagnoses. And this was developed by a team at Columbia University. Finally, a really important question is, what is INARMS going to do? What difference is it going to make? As was mentioned, there's a really big gap in the data at the moment, especially for Indonesia. And by addressing this gap and having nationally representative information about the actual mental disorders that are being experienced by Indonesian adolescents and their prevalence, this is something that can be used by governments, policymakers, and other organizations to specifically inform the interventions and treatments that are actually being used, as well as having this information about the different risk and protective factors that contribute to mental health, such as education and things like that might be important. This can be used to further target interventions and make sure the policies that are being put in are actually beneficial and are something that will hopefully make an improvement to these mental health issues. As well as this direct benefit, this data is going to feed into the GBD study. So by having this data available for Indonesia, not only will it increase the amount of data that we have on Indonesia, but it can help inform better prevalence estimates for the surrounding countries. So it's going to help to make better estimates of information for all of Southeast Asia. And like Holly showed before on that graph, we can see a better cross-national comparison. So we're going to be able to see if the prevalence is changing over time, how this compares to nearby countries, and this can further inform what needs to be done by policymakers. In addition to this, by having this instrument that we've got, so the DISC-5, as well as the fieldwork processes and things like that, this can help to inform later studies. So other countries and surrounding areas can continue to do nationally representative studies using a similar methodology. And finally, the most important reason or motivation behind doing any research project is that this is going to help to improve the lives of adolescents living in Indonesia, as well as their families and the broader communities they're a part of, by having accurate data on their mental health disorders and knowing what can be done to help treat these. For this next section, I'll pass back over to Holly, who will speak a little bit further to this.
Great. Thanks so much, Katia. So I think, I'll let Amira reflect on INARMS a little bit more, but really this is such an exciting project because all those challenges that I mentioned, essentially INARMS has been built to address all of those as best it can. But I guess then after, everything that we've spoken about, the question always is, and fairly is, how is all of this relevant to clinicians? So, people such as yourselves going and seeing and treating patients, how is all this information relevant to you? I guess there are a few points, and I will hand over to Amira to comment on this in an Indonesian context. But from our perspective, it's the awareness of adolescent mental health, its importance and impact, and also the scope of the issue among Indonesian adolescents is really important and I think helpful for clinicians to know. So knowing who is likely to walk through your door for treatment and other, issues that may be going on in addition to whatever they are currently presenting with. So they may come in for, something related to physical health, but there might actually be, some either mental health problems or a mental disorder happening as well. From a patient, I guess also from a clinician perspective, it's helping to reduce stigma as well. So with mental disorders being the focus of this kind of research, it really does help bring mental health and mental disorders to the fore and reduce stigma. So reduce the stigma about talking about them, about recognizing them, and about treating them. It changes the discussions both with patients from your perspective and of course policymakers as well. And I think changing the discussions with patients is a really important one because that's where the potential for early intervention lies. And as we noted right at the beginning of the lecture, and a mental disorder or poor mental health in adolescence can really have some significant adverse impacts for a person both currently and later in life. So that potential for early intervention is really, really crucial. It also directs serious thought into how to address the burden associated with health conditions like mental disorders. So that's both from a policy perspective, but also from an actual evidence-based treatment perspective. And finally, I think this lecture is case in point. It impacts what's taught to future health practitioners such as yourself. So I guess on that note, Amira, I might hand over to you just to perhaps reflect on some of this from an Indonesian perspective, and also if there was anything you wanted to touch on about INARMS as well.
Yeah, thank you, Holly. I think I will start from the reason why we discuss this. So again, the topic of this course is about adolescent health, and it would be incomplete if we discuss adolescent health and well-being without discussing adolescent mental health. And this is because also I also reflect on my education, my education during medical school. And I'm sure, it's been years and the curriculum might change, but during when we discuss the health cycle, the life cycle, and we discuss adolescence itself, I think if as far as I can remember, we only, at least for my batch, we only discussed conduct disorder that, it's really regarded as mental health problems that, linked with adolescents. First, I would like to emphasize that during this session, during this lecture, we see that there are more, more conditions that related to adolescence itself. And this is particularly important because even psychosis like schizophrenia often shows the symptoms during adolescence. And sometimes because we are not really, pay attention to it, it's just, go unnoticed. And therefore, when the person hits early adulthood or even like later in their adult life, the symptoms will be so severe. And we know that unfortunately in Indonesia, the number of psychiatrists and clinical psychologists available is limited and not evenly distributed throughout the country. So it's getting harder and harder to access for help. So starting from this, information, later on you will go through your clinical rotation. Of course, you will have around 4 or 6 weeks in psychiatry department, and but mostly so far you would see psychosis patient. That's where the bulk of the issue in our academic hospitals will will manage. But after that, you will have your medical internship, and you will go to community health centers. And at least if if you if you have your placement in Yogyakarta, for example, all community health centers in Asia in Yogyakarta um, have either have clinical psychologists, and it will really depend on the general practitioner and the clinical psychologist to work as a team to first conducting a screening among high school children, or conducting like a community counseling, or maybe like just a session with the parents to understand more about um, mental health issues, particularly among adolescents. And you will see that you will see that this is not an isolated problem. Like, it's really common. And because again, back to the rapid changes that happens in adolescence, and also the stressors from surrounding that will be like confusing enough. And and there is also challenge, especially for like in current situation when we deal with pandemics and everything. So I think the first take home point that we would like to emphasize during this lecture is first to make sure that you have an awareness, just like the slide mentioned, what Holly mentioned before, to have an awareness that this is an iceberg phenomenon, I think. So it's big. We don't have a good data in Indonesia right now, but I would bet, and I would bet anything on anything, that once we go to the community, once we serve as the general practitioner, for example, you will see that this is a common health problem, not only even in general population. So you can imagine that in adolescents, this would have a significant proportion or burden of disease as well. And then once we start taking it seriously, we can start thinking about what we can do to help. And although it will be a learning process, because you will graduate as a GP, not a psychiatrist. So you would need some additional trainings, maybe, or maybe you will also need to build a networking with a higher level of service, whatever it is. I hope that with that sense of awareness, and you will start taking this issue seriously, and then it will give you an opportunity, I guess, to help your patients or your community where you work at later on. And again, if I know that some of you, for some of you that might be interested in working on this issue, this topic, like Holly mentioned, currently we already we just finished our data collection in INEM, so we are gearing up for data cleaning, and eventually data analysis. So we will know we will know more about the status of adolescent mental health in Indonesia. If this is something that you think that you are interested on, feel free to contact me. So we can, starting next year would be there will be many interesting thing that we would do together. And this is again a collaboration between UQ in Australia and my alma mater, Johns Hopkins University in United States, and UGM. And and we also work with USU and UNHAS in Medan and Makassar respectively, and there will be two other countries involved in NAMS, Kenya and Vietnam. So this would be a big experience. Like even for me, this is an important learning experience. So so far we can see that again, language and culture are really I really want to avoid naming them as challenges, because like it is what it is. And I think Holly and our UQ colleagues can also emphasize that mental health is really related to the cultural aspect of community. Like I believe that Holly before mentioned about truancy, and this is not something that common in Indonesia. So I first learned about it when I was in Baltimore, and I guess like it shocked me that a school a student could be arrested by a police if he or she how to say it, like he or she just skipped school basically. So this is called truancy, and we don't have this in Indonesia. We don't have this concept that if you skip school, the worst that could happen would be like your parents could be called into the principal's office. And there is no I remember I skipped school in junior high school, and we got caught by the security service because I went to a private school I went to a private school owned by oil companies, so they have a security service. So when we skip school, these security members just pick us up and send us back to school. And then after that it would be the teacher would call our parents and there will be punishment, but that's it. In contrast with like in the United States, for example, you could get caught by police and there would be I don't know for sure, but there is a degree of law implication because you skip school. So this is just one example, and not to mention that in Indonesia we also we have a significant beliefs in let's say traditional healing, which can help or hinder our mental health campaign or mental health awareness program. And this is something that I believe that will not be the case in Western countries, so to speak. So in we need to remember all of this in the way we approach this issue. I think that would be the main the reflection that I can share, because at the end once once you are in the community working as a GP, it's really it's really a matter of understanding your community, understanding the population where that you serve. So put that in mind, and then after that, uh, implement your knowledge, not the other way around, not stick to your knowledge without, like, um, and make the culture or religion or whatever it is in your community follow you. That will never work. I think that would be all for me, Holly. If there is anything else that you want to add, or Cartia, Christina, I also invite the students, if you have any question, you can just unmute your mic or send me the question if that's something that you feel more comfortable to do.
I would like to ask something, if I may.
Okay, so who is speaking?
Prayoga, Miss.
Okay, so we have Prayoga, and then Wilson also raising his hand. So we start with Prayoga first.
Okay, thank you. Okay, my name is Prayoga, and I would like to ask about a few things. First, what do you think causes mental health diseases to increase these past years, and what do you project the trend will be in the future? And are there already any effort made to overcome cultural differences in mental health survey? Thank you.
Thank you so much. Amira, I can have a go at answering that question. Then if you'd like to jump in.
Sure.
Yeah. Brilliant question. And I think if I knew the trends of what was going to happen, I'd probably be able to retire. But I think, what we are going to see, I think we will see an impact of COVID, both in terms of the stress, clearly that COVID has had on everyone's lives. What we're also going to see potentially is what we call the third wave, or, however many waves we're in at the moment. And it's really about people not seeking treatment for mental disorders because of COVID. So they're less likely to access any available services due to a fear of contracting COVID, or due to those services being overwhelmed. So I think, as I mentioned, what we'll see an uptick in prevalence. We'll also see a little bit more of a delayed increase potentially in prevalence as well, due to people unfortunately not intervening for their mental health as early as they should. I think with that, again, being able to predict trends also comes down to the data that we currently have as well. So the more data we can get, the better we're going to be able to get at predicting those trends, as well as what's coming now. With the cultural adaptation of the tools that we're using in the survey, I think it's one of the great strengths of INARMS and also NARMS more broadly, has been the cultural adaptation of those standardized tools, so the DISC-5. And that's involved quite a lot. So it's involved not just translating, but also having those translations back translated and assessed by us. It's also, there's been a huge amount done by Amira and her team, having those translations reviewed by clinicians, having those translations reviewed by a range of people, and then also doing a pilot study as well to see how well they actually act in the field. So it's not an easy thing to do, and I wouldn't say that we've done it perfectly, because I think it's impossible really to do something that is so, set in culture absolutely perfectly. But I think, we've got every confidence that we've got a unique product that will be able to be compared between three, very different countries, with Vietnam and Kenya. Amira, I didn't know if you wanted to add anything else to that.
I think, well, I think I only want to add that as for now in Indonesia, we also see more awareness in general regarding mental health. And I don't know if you know this, but well, I believe you do. I mean, in even in social media now you can see that many NGOs or many partnership that pay attention to mental health. So I think uh, I hope that this means that we will take this problem seriously, not just as an anecdote, like oh, this is just because you are not religious enough, or you should go to the mosque or to church, or whatever, whatever your religion is, you should pay attention to your religiosity more. So I hope that it means that we will see less of this, but at some point it means that we also need to invest more on the access, or the 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 health providers, the mental health providers itself. As part of INAMS, we partner with the Ministry of Health for particularly their mental health division. So as for now, I can share that they really pay attention on suicide among youth. So one of the data that they request from INAMS, hopefully next year we will have this information, is they ask us to analyze, the suicide among youth, among adolescents, and the predictors, the variables that involved in this issue, in this phenomenon. And at some point, we also need to as you know, and Holly, Christina, and Kartia, you might also aware of this, that we are currently in our war on drugs era. So uh, using drugs, even in the small quantity, is a criminal act in Indonesia. And I'm not saying that this is wrong. There should be a good control system for drugs, but at some point, it seems like we are criminalizing an act that should be treated as mental health issue. So and this is not we are not just talking about the let's say like heroin or marijuana or other psychotropical drugs, but we can start from smoking. For example, Indonesia is one of the countries in the world with the highest smoking prevalence among youth. So and all of this, although like before I delve further into this issue, I didn't think that this is a mental health issue, but later on, after reading more and involved in this research, I could see that yeah, this is a mental health issue, and people, basically like youth, Indonesia, are aware that should be help, or help that could be accessed, and we are not there yet. So that would be our homework, I guess. Yeah, I think that would be the thing that I would like to add. I think Wilson also wants to ask some question.
Yeah, thank you, Doctor. Before, thank you so much for such eye-opening and well-put presentations, also for the initiative to close mental health data gap in Indonesia, especially for children and adolescents. I personally have faced challenges during discussion with some stakeholders who belittle the urgency of children and adolescent mental health due to the lack of data and research we have on that matter nationally. So I actually have three questions. My very first question is, as you mentioned earlier, one of the barriers of doing such measurement is cultural barriers, putting into context that the diversity that our nation has in terms of culture, language, and religion. How do enums accommodate these differences, and what are the current limitations that enums has And my second question is, why did you choose Vietnam, Kenya, and Indonesia for this survey? And the third question is, I'm also intrigued with the extra modules that you added to ENAMS regarding national health insurance, as universal health coverage has been mainstream in many countries, including Kenya and Vietnam. And please correct me if I'm wrong, but I think Kenya and Vietnam also have some sort of national health insurance scheme. Why do the national health insurance not included as a factors in KINAMS and FINAMS? Thank you so much.
Thank you so much, Wilson, for three very well thought through questions. I think I can speak partly to the first. I'm happy to answer the second. And then Amira, I might leave the third about health insurance to yourself. So I guess from our team's perspective in terms of the cultural barriers, and you're absolutely right, there's such variation both between our three countries and within our three countries in terms of language and religion. So I think a lot of effort was put in not just to the tools themselves, but also the actual kind of fieldwork methodology as well, and ensuring that was as culturally sensitive and appropriate for whatever area of Indonesia that was being done in. And, you know, Amira, please correct me if I'm wrong, but in some instances that would mean ensuring that the interviewer was female instead of male, and just different, I guess, considerations around that as well. And I guess I did focus a lot on the disadvantages of the standardized tools, but there are also some advantages in terms of field work, because with the standardized tools, we're not asking people, do you feel depressed? Because, you know, that can, people's understanding of what depression is can really differ. You know, it opens up a whole range of problems. Instead, what we ask about are actually the symptoms. So do you feel sad? Have you felt irritable? You know, with anxiety, have you felt nervous or worried? Was this in a social situation, in the case of social phobia as well? So I think as much as possible, we tried to really maintain that balance between being conscious of, you know, different language challenges and different sort of cultural contexts, while maintaining our ability to compare across countries. And I think the big advantage for INAMS and for NAMS more broadly is that often these kinds of surveys are done very separately. So even if a survey is being done in two countries at the same time, those two countries don't talk to each other. You know, it's done completely separately. Whereas in NAMS, what we actually did was everyone worked together. So the 5 teams, so UQ, UGM, Johns Hopkins, and then our Kenya and Vietnamese colleagues, we all really worked together to get a tool that suited everybody's you know, culture as much as possible, flexed it where we could, and then maintained consistency where we couldn't flex it as well. And I think as part of that, there was a lot of learning you know, for everyone in terms of what some best approaches might be. You know, so that was another, I guess, advantage of the project that we didn't necessarily anticipate. Just before I pass over to Amira, I will answer your second question, which was around why were Indonesia, Kenya, and Vietnam chosen? Again, brilliant question. So from the funders' perspective, so we are funded by the University of Queensland in America through a gift from Pivotal Ventures, which is one of the, it's an incubation company by Melinda Gates. And there's a few different reasons, I guess. So first and foremost were countries that were presenting an increased interest in adolescent mental health. And also countries whose Ministry of Health were interested in this topic. As Amira mentioned, the Ministry of Health in Indonesia has been involved from the very beginning. And we also wanted to partner with organizations who had experience in conducting sort of household surveys, not necessarily mental health, but organizations who would then be able to carry on these new skills to future studies and also other similar organizations within the country. So it was really thinking about not just what is going to happen now, but also what's going to happen later on as well. So, you know, and also I guess from an international perspective, GBD that I mentioned as well has a strong interest in these three countries, particularly given Indonesia's population size and, you know, position in Southeast Asia and also sort of the Pacific region as well. So I've partly answered your first question. Hopefully done justice to your second question. And Mira, I will leave question 3 to you as well as the rest of question 1.
Yeah, so starting from question 3, I guess, I honestly don't know the status of universal health coverage in Vietnam and Kenya, but the specific interest that we have in INAMS regarding health insurance is because we are practically new to this. Like we started this in 2014, and now we are less than 10 years in implementing this issue, and we already reach around 85% of population, I guess. So the interest that particularly for Professor Siswanto Wilopo, because he was he was involved in some of the you know, like the incubating basically the idea of universal health coverage, and he is also a professor in population health. So the basic interest that we have is to see the difference before and after universal health coverage, before and after we have BPJS. And this might not be the main interest for Kenya and Vietnam, because maybe they already have an established system, so it's not a new thing anymore for them. Again, you know, like comparing to in you know, our situation where this is still something new, and you know, we are still in terms of mental health, we are still advocating for example, make sure that mental health medications are included in the refile system in community health center, and to increase the access because in preparation of the survey, we had to collect the information about the number of mental health hospital in Indonesia, and it was quite surprising for me that not all provinces in Indonesia have a mental health hospital. And even when they do, you know, you can imagine there is one mental hospital in Central Kalimantan, for example, and you can already imagine how big Central Kalimantan is and how difficult the terrain, the access to get there. So I think that's the main reason why we include this in our survey. And NAMS overall also gives us some leverage for our you know, our cultural specific perspective, so to speak. Like other two countries don't have specific instruments on religiosity, but because of recent surveys, not particularly in mental health, but in other health-related survey, shows that Indonesia population is pretty, you know, concerned about religiosity and how it will impact or influence the health-seeking behavior, for example, or their coping mechanism on adverse situations. So we include this. And also there is one difference in the way Kenya calculated their wealth index, so their economic status versus what we have in Vietnam and Indonesia. So it's still comparable, but there is slight difference. And that's, I think, for question number 3. And for question number 1, the effect of cultural difference in Indonesia, it's really, we are, of course, at this point, what we have is the evaluation from our enumerators. We employ more than almost 200 enumerators all over Indonesia, and we in a good communication with all of them. So we have like some input and also evaluation from their field work, and we can see that this some of the questions, for example, will not work in certain part of Indonesia. Like you can imagine, like in Sumatra, for example, talking about private matters, like do you feel sad, or do you feel like you don't want to get up in the morning, things like that would be like the rather than answer, there would be like, why do you want to know? That would be, even after you explain, the purpose of the study, that they want, that they are free to participate or not. And there is also this like cultural thing to we call it social desirability bias. So when somebody asks you a question, you really want to appear good. Like when somebody asks, let's say that we have a question here regarding sexual relationship. So when you ask teenager whether they already start having sex or not, there is this pressure to say no, so because that's what our culture taught us. So and this is also like a challenge. And also there, because in INEMS we work with adolescents from 10 to 17 years old. There is a big difference in their understanding, in their comprehension. Like when we ask, like we have a question about gender identity, I guess. Yeah, gender identity. So ask whether they identify as male or female. When we ask this question to 17 years old or maybe 15 years old, they kind of understand, yeah, I know what you are asking. So they could give an answer that reflect, this situation. But if you ask this question to 12 years old or maybe younger, they would be like, huh, what are you talking about? I don't understand. So even in a, and I believe that this is also a problem in other countries, just because we are dealing with developmental process. So we are not even go through and also because in our culture, it's not something, this issue is not something that we talk about freely. And this is sometimes considered as taboo. So this is by no means the end of the survey. So even after we have the data, even after we get the result of prevalence, I believe, and Holly, you can add to this, I believe that there will be additional work to, for example, if we want to adopt these 5 into our daily practice, let's say that we want to adapt it so all community health center can administer these 5. So we have a screening system in place. There will be some additional work to make sure that it will be beyond the survey to make sure that it will be suitable for the community. And yeah, this is a work in progress. And but yeah, I'm glad that at least we are starting the process. Holly, is there anything that you would like to add?
No, I think you've really covered it all, Amir. I guess, you know, again, looking at those standardized tools like the DISC-5 and potentially incorporating that into, you know, some kind of clinical setting as well, that's really also where sort of the length of those instruments comes into play as well. So even though the DISC-5 itself might not be appropriate, all of the work that has gone into adapting the DISC-5 for iNARMS are learnings that can then be applied to another instrument, which might be a bit more suitable in terms of length. So I think not just the actual results of the study, but also a lot of the methodology and the development, hopefully, if it's picked up, is really, really going to be valuable to clinical practice.
Yeah, you're right. So I guess I just want to open the, you know, an opportunity for other students if there is any question. I believe that we only have 3 minutes left. I think yeah, if there is any question, feel free to ask. But I think I just want to ask, you know, just to you know, like to ask you on your perspective, you know, like you have your experience in Australia, and I guess, you know, working with University of Washington as well, so you know what happened in Western country, or, you know, like high income countries. What do you think would be the biggest difference or the biggest gap between high income countries and low and middle income countries in terms of maybe prevalence and also, you know, the challenge that will lay ahead?
I think that's a really interesting question, Amira, and I guess the answer depends on, you know, the perspective from which you look at it. I mean, from my background and my training, my initial response is always data availability. So really what we see is significantly less data available for mental disorders across all age groups in low and middle income countries. And you know, this is despite the fact that low and middle income countries tend to have much younger populations. So when we're talking about adolescent mental health, that lack of data is even, I guess, more potentially impactful in Indonesia than it is in a country like Australia that's already had 2 nationally representative surveys of children and adolescents, the most recent being in 2014. I think, you know, in terms of impact, you know, it's what I would say as well is the comparison is always spoken about, I think, from a more negative perspective. But an interesting article I read once said that there's actually a lot of lessons to be learned from, you know, places like the US and Australia and UK about what not to do. So there's sort of the potential for lower middle income countries to leapfrog, you know, the mistakes that we've made in the past with how mental disorders have been treated or have been addressed. Also, I guess mental disorders are coming to the fore now, you know, in these countries in an age where we do have better treatments and we do have better technology. And it's about, you know, I guess, learning to or looking at the best ways to adapt that to address, you know, mental disorders and also to improve mental health more broadly as well. So it's a tricky question. I think if you asked a clinician, it would, you know, the answer would be really different again. Mm-hmm. But I guess for me, you know, what I hope everyone takes away from this is just mental health in adolescence and in any age is really important. If we don't have good data, we can't make good decisions. And there's also a lot of benefits from a clinician's point of view, you know, for being aware of mental health and well educated around it as well.
Yeah, you're right. So I guess we're right on time. So, and I hope this would be useful for all of you. And thank you for joining in this lecture. And I can say thank you enough for Holly, Christina, and Kartia first to participate in this course and also to, giving an awesome lecture. And I hope as well, because obviously our UQ colleagues are more experienced on this issue compared to us here in INAMS. If you think that you would need more information or just more knowledge on this, feel free to contact me and I would see what I can do to link you to this expert. And I think that would be all from me. Holly, is there any, closing statement before we part?
Look, I guess nothing further from us. Very happy, Amira, to answer any questions that come through after the lecture and be put in contact directly as well. And just thank you again for the opportunity to lecture. It's something we really, really enjoy. And, you know, hopefully, even though everyone is tired at the end of the year, you all got a lot out of it. So thank you again.
Yeah. So, okay, guys. I think this would be the end of it. And I'll see you again tomorrow. And thank you. Have a good day.